아팠어요. 시험 때문에 사람들이 빠졌어. 그래, 뭐야?
Good morning to Professor Wan, Professor Peck, and my colleagues.
Please speak louder.
I am Dr. Georg, now currently at EP Fellow in Sovereign Hospital, Yonsei University College of Medicine. Today, I'm going to present my EKG conference. This is the first slide for my ECG. It was taken at February 2025.
Okay, who will start first?
Dr. Hyun Soha, please. Present.
Who?
Dr. Hyun Soha.
Oh. You look a little embarrassed. I there are looks like basically sinusoidal and right on the block. Very frequent BBC right after the sinusoidal. Okay, PVC by Gemini? Yes. Are you sure it is PVC or APC with aberrance? If you see the white cloud complex, we need to differentiate aberrancy on the branch block, excitation is real, right? Of course, the probability of ventricular is most common. So PVC, that region exists is first. No. I'm asking. First of all, is it PVC or other one? You cannot see the premature P wave, and you can find it, and there are this not check the this. So because of there's no preceding P wave, yeah. So it is the highly likely the PVC. Okay, and
So normal scientific will be PVC. And PVC morphology RBV and QR duration 0.2 and transition zone is V4. V5 is more than R. Enter. I think we two things, testicular with temporal, testicular with or testicular with muscle, PVC.
That's one muscle or vascular PVC. Okay, good. The heating substance. So where?
I think these 2 and 3 is PVC is maybe one comes from not just because it's a bit narrow than like it's from the American system. I'm restricting people by Germany and consumption in house.
So you prefer vascular PVC? Vascular PVC. That's it.
More than narrow than very much. Okay.
How do you think? Yeah.
I agree that this is key and its localization is looking like this RGB and mirror carry on of this. Reader back to what? There's a small Q in one. I think it's more than I think it's fairly most weekly from maybe stadiums better than basketball.
Okay, so Jogaya, actually, is different.
Also popular in BBC.
Okay, so please the list of which finding the favors popular muscle, which one favor? Last one. Number one,
Number one is the specific more QA in one
do you want smoke favors?
favors the
Popular
popular
muscle, okay,
And Georgia mentioned that relatively narrow diets for the VC, but popular muscle also show relatively narrow one.
and second one,
No, its duration means that both possibility
okay,
and
I think you want to exhibition.
one by one. RBBB,
Maybe both are.
okay, typical RB pattern favors vascular. And this is reverse RBBB
Yes.
pattern, favors popular muscle, okay, and third one, transition. Next to transition, offensive reflection. And if there's AV QA, small QA favors vascular. So it's mixture, right? Okay, let's listen to Dr. Huang's interpretation.
My question is, if you look at the lead two rhythm strip in the bottom, the sinus rhythm or T wave is notched. What is that? First question.
That was a prepared question for you.
I'm just asking because
You see the ST segment is, there's a notch more undulation, right?
no, just no, I'm not talking about the sinus rhythms.
Yeah,
T wave is notched.
yeah.
Is it normal to have a T wave notched? That's what I'm asking you. You guys always, everybody talking DT, DVC. Is there possibility of another wave into that T wave? You don't see this type of T wave, do you? T wave always like a beautiful, nice, smooth, like lead one, for example, a little bit better looking. But you can see 2, 3, yeah, all have a notching. Exactly the same timing. So then someone might raise you, why this cannot be? Parasystolic PAC coming with the aberrancy. You need to think about those things. I'm not saying that's a diagnosis, but we need to start thinking why the T wave is notching. Is the artifact? Or this is a truly real meaningful thing?
Okay, let's.
I'm just throwing question, and then also one more thing. And then after the QRS complex, the aberrancy, whether or PVC, there's an upstroke, and the S wave upstroke, there's a notching also. No, PVC, come to PVC, yes, S wave coming up, right end of it, right? That's it. So, two questions, is this the T wave initial notching, and this notching has a relationship to it? Or there's a retrograde P wave, whatever it might be? Possible? But then what would be the causing of this? We have to answer those things.
Professor Kim.
I agree with Dr. Huang's opinion.
Sorry for what? Is it P wave? Artifact?
This ECG is not an easy ECG to read. As to you guys think, there's many things here that you're missing out right now. Okay, I'm just gonna give you one more clue. Look at the last bit of a PVC, end of a T, what you see? No, we're moving, the last bit, PVC. Move right there. That guy,
That guy.
what is that? That, then you can answer what is that notching in the end of a QRS is.
P.
Block? P wave?
P wave.
No, yeah, block the P wave.
Yeah.
So there is no. What does that mean? The terminal noisy is not a. Yeah, no, just terminal S. Yeah, the noisy cannot be atrial activity.
Yes.
Mm.
It's gotta be part of a ventricle. That's what I'm trying to make it point. Okay? So this patient has a ventricular phasic P wave there because your PVC pushed the sinus firing faster. So that's why PP interval is shorter, subsequent P is longer. So this patient does not have a good VA conduction. Okay? Therefore, there is not, cannot be that terminal S is atrial activity. Gotta be more likely favorable ventricular complex cell. That makes sense now. It's a series of fascicular VT versus fascicular PVC versus capillary PVC. Which one? That would answer your question, I guess. This is probably more favorable capillary, not the fascicular. Okay. Second point is, what is the T wave notching? Yeah, that guy.
That guy.
We have to answer that. If this is a summation of another extra atrial activity causing aberrancy, then your diagnosis all wrong. This is aberrancy. But the QRS morphology of precordium does not suggest a pattern of aberrancy, right? This favorable. The B1 has a double notching, but in the first S is, the R is taller than second, and then even B2, B3. So this favorable PVC, ventricular origin rather than supraventricular aberrancy. So then we need to answer that T wave. What is that T wave?
That's the depolarization on the molecule.
Mm-hmm.
Because the
That's right.
polarized to lead to ABF.
Yes.
And the B
Interiorly,
4,
right.
B4, 5. So that location is exactly matched to the location of posterior pectoral muscle.
Right.
And likewise, the epsilon wave or
Right.
J wave, if there's a depolarization delay, probably those fractionate potential.
If you look at the lead 2, 3 ABM, what is missing there? S wave, small S wave. Normally, sinus rhythm would have Q, R, S, and then S again, right? There's no S wave, it's just smooth out, rounded up. Only interiorly. So this patient has pathological focus originating from the posterior papillary muscle. And therefore, Dr. Park's argument that there could be similar reproducibility suggestive of J-POI elevations or J-wave syndrome and so on. Okay?
Okay.
Wow, you all found out the treasure ECG.
So sometimes EKG looks simpler, but if you look carefully, they'll tell you many things. So you know what I'm telling you, you can look at the B4. You see normal sinus has a small S right there, yeah,
Yeah, small S.
but only interiorly you don't have. Okay? So this regional variation is important, and lead one also have a small S. Yes. Okay? So like a intracardiac EGM, you need to look at things carefully. It's not as easy as a lot of people think. So keep training your eyes. So this is agree, is a bigeminal PVC. And then what is the mechanism of PVC? That's all. One more step forward now. Is the parasystolic mechanism? Bigeminy could be parasystolic or could be trigger activity. It will not be necessarily parasystolic. But the fact is that the patient does not have a good VA conduction, probably the parasystolic mechanism. I wouldn't say 100% sure. I hope with some irregularity, they would confirm the diagnosis, but then most likely parasystoly, therefore most likely automatic focus. Okay?
So let's vote at this moment.
That's.
Okay.
Vascular. Raise your hand. Nobody? Okay, you can argue.
No,
It is not democracy.
yeah, no, I mean, we are adding the probabilities here. I don't have a, guarantee answer either, but I'm just pointing out the fact that why this is not like that, okay? That's only reason. Okay. No.
Vascular? Nobody? Vascular muscle? Everybody?
No, the question is then, how do we differentiate posterior vascular VT originating from the near the papillary muscle? You cannot tell the difference. Okay, so that possibility, I would add a differential diagnosis. So there are some features that here that more striking adding to the papillary muscle because the lead one is biphasic, PVC. You see equal size of a PQRS complex. That's another feature.
But still, I'm not comfortable to decisive.
No,
It is performance
No, you can't.
because the intrinsic deflection time is too sharp.
well, but the other argument would be lead 1, 2, 3 F your R rate initial rate too big. Look at the lead 1 as you go higher up, lead 1, 2 PVC. Lead 1 R rate, initial R rate, go down to lead 2, small, slightly smaller proportionally, lead 3, and even smaller. So that would be against the fascicular VT. Okay, so I think this is, as I said, probably papillary muscle PVC invading fascicle very early, or could it be a posterior fascicular PVC cause of papillary muscle? Either way, we could never would answer that question. Okay. But again, you have a posterior fascicular area. There's so many network of Purkinje fibers.
Some pathology.
Definitely not. This is not normal. Also, this patient may be high risk. Because if you look carefully, he will have amplitude vary a little bit too. So this is something not normal, this patient. You really need to look carefully.
So. Forehead.
What did you find?
This is another slide of ECG. This was taken at June 2025.
Okay. So this patient still have a reproduction abnormality. You have no acute S wave of 2, 3 in AVF study.
Need to. The J wave like,
Up and down,
yeah,
up and down.
disappear,
Yeah.
right?
Yes. Is that normal? And looks like first to the second coupling of QRS to the PVC, the first one, lead to go down to bottom strip. Yeah, that interval to the second one. Did you measure that? It's same? That one to that one? Preceding QRS to that one. Yeah, that to the next one, the QRS, PVC, yes, to that second one. It's changing a little bit.
This is wider.
Hard to know. Probably pretty close, but I think the second one is a little longer. Right, so therefore this is kind of more considered parasystole rather than it's, okay. Yeah, and then also you can notice that the QRS complex and the PVC, the B1, B2, B3, also notching the changes. Obviously, it could be replacement, but I don't think this is a little bit wider. Okay, but this is favorable papillary muscle, maybe changing. This is something fishy going on this patient. So what's the story? Next.
This was a brief history. The case is 57 years old lady. Chief complaint is she discovered PVC during medical checkup. A past medical history was pH repair for pelvic organ prolapse at 2018. Echo show normal size carrier chamber with normal ejection fraction 64%, relaxation abnormality or LV filling pattern, EE prime true, and memo report show PVC is 20.75%.
Okay.
This is a chest X-ray. Increased cardiothoracic ratio.
So This heart is normal. Chest X-ray? Not normal.
Increased cardiothoracic ratio.
And then which one is increased, LD or RD? I'm asking too many questions now. Tip is dipping down to diaphragm. Dominantly LD. Okay? When the tip is up, it's usually RD, like a bush shape heart. what we call.
Shape.
Yeah, this is not a bush shape, dipping down. This young lady. Okay,
This is the ECG. It was taken at 2018.
the still reported still. That's why it's not there. Okay,
This is the electrophysiology findings. EPS and RFA was 10 at 4th July 2025.
Yeah.
And this is the VVC originating to posterior papillary muscle and successful RF ablation of VVC originating to posterior papillary muscle.
and did you do induction study in this patient? EP induction study. That would be more curious for me now. So did you stimulate to induce any other ventricular arrhythmia during the study? We just suddenly walked away. It's hard to know you don't say it. I assume they did, you did, stimulate a ventricle. Okay. So that's why you see fundamentally important when you young generation people bring this kind of idiopathic, you assume idiopathic PVC patient, whatever, you need to complete study, okay? Don't ablate before. Because of this patient, also, we always talk about this again. People who have a frequent PVC have a much higher incidence of AV NRT induction, okay? Don't miss that. Would be sad that you ablate the PVC and patient come back later with the SVT, then you miss the whole ballgame. And in reality, the patient's symptoms more dominant of the AV NRT rather than PVC. So by far SVT, most symptomatic tachycardia is AV NRT. Okay, so that can cause dizziness, syncopal episode, and so on. AVRT very seldom does that, unless you have a posterior X-ray pathway. So it's something that you need to pay attention. Okay, please do study and evaluate. And this patient would be very interesting because you got reproductive abnormality. You should study. So,
But do you recommend the study before PVC ablation or after PVC ablation?
before.
But I have several experience after pacing study.
Did that appear?
It's very- Yeah.
Oh, then you can do after, but typically we like to do before. Okay, because we want to see, for example, we want to see what's the PVC interaction with the nodal VA conduction and so on. That's the important aspect of thing. Second, as you know, Japanese guys published many serious cases of double tachycardia simultaneously. Patient having AVNRT, posterior vascular VT back and forward. Same patient. There's many cases published. And we saw one case also in Myanmar like that. So double tachycardia do exist, is a real thing, especially young patients. You really want to know all of that before you play. Don't miss out, please.
But I have been teaching my fellows
Mhm,
if they use ablate to frequent PVC,
mhm.
if you see PVC ablate first, then after.
Well, either way, I think it's acceptable.
Basically.
You're right, as long as you do it all, right? But we prefer the first before, because I had a painful experience also myself many years ago. We did AVNRT patient, got the AVNRT, and then patient come back week later with a vascular VT in emergency room. I said, what happened here? Because I did not do full VT study on that patient. That was very sad. I felt sorry for the patient. I had to take it back to the lab later. So goal is to try to do least invasive possible, one time take everything and then you're done with that. That would be your job, rather than keep bringing patient back. That's not a good for patient. Plus patient look at you, oh, this guy didn't do anything for me yet. What did you do? Looking at the face, it looks like you're stupid or something. You just not a good feeling. Okay?
This is
Even after ablation, you have no S-wave still.
this
See
is a
the
less
T-wave
ECG.
abnormality still persists, the flat T-wave? Could you get? Yeah. If you get your T is not normal, reproductive abnormality still persists. And then she have a reproductive now, you go to B5. And that recording that normal. T-wave, look at that, inverted all the way to D5. It's not normal ECG, okay? So need to be a little bit cautious when you read ECG, okay?
So UA became
Right.
prominent in B2 and 3.
Right?
That's related to extensive ablation.
That's a bit.
UA generally the
Applied muscle,
yeah is made by capillary muscle repolarization.
but not necessarily all of that. But fact that TB4, B5 is, unless you really learn a lot, I doubt it. But then patient has this temporal variation of repolation abnormality, also another additional diagnosis, repolation abnormality. Sometimes significant autonomic dysfunction, like a cerebral T wave and so on, acutely you can see the T wave abnormality. It goes away once patient can resolve. But this patient factor that persisted back and forward, including interiorly, yeah, patient definitely had some issue with the repolation. If the diastolic heart failure has a relationship to it, possible, but then this patient has a diastolic dysfunction.
E prime is 12.
So what are you doing with the diastolic dysfunction in this patient? Do you treat the patient or not? How much body weight this patient? Was it heavy lady? X-ray doesn't look small. When I saw the chest X-ray, it looks like it overlaying some tissue in the side, chest X-ray. Okay, here, it's not thin lady, it looks like the heavy side, the Korean lady, yes. So need to have a weight reduction and all this stuff has to be done. Also hypertension, make sure it's not there. You can do the best you can. Ladies tend to develop more diastolic heart failure anyway, natural history with cardiology. So you have to.
카로세로 비율이 맞는 거야. Is it correct? The
I think it is.
longitudinal ratio.
It is. Watch chest X-ray, look at the abdomen, how big it is.
I feel the
Little
shoulder
bit short.
length is too long.
Shoulder length is too long.
The big lady, the big lady, that's what I tell you, the big lady, look at her arm. You got humerus right there, and then she got huge shoulder. So this is not a thin lady, heavy lady.
So can I give
Yeah.
a very minor comment?
Yeah.
It's not about.
Sure, I told you, yeah.
You use the term of memo report. To for that is not apparent operating term, yeah, it's just a brand name.
Oh, brand
So,
new.
yeah, use a single reporter,
Name.
whether wearables, yeah, wearables.
Thank you.
That's a you comment is a very valuable, but you need to use a common terminology for all of us, same way, okay?
Name.
Use the,
Thank you.
is the medication, yeah, is the. Not generic name.
Right.
but For.
You should describe disclosure information if you use memo.
Anyway, I feel like, why, good case, good ECG.
Thank you.
Thank you for your attention.
By the way, next week, I am going to give you guys the EKG presentation, also case. Then I will give a lecture about the first clinical lectures of EP for fellows.
So glad.